Hello, everyone, and welcome to another session of the Cancer Survivors Park Prevention and Wellness Series. My name is Julia Humphreys, and I will be your host today. Today, we have two special guests joining us from Gibbs Cancer Center's Comprehensive Lung Cancer Program. Chad Dingman serves as the Director of Oncology Support Services and Center for Integrative Medicine at Gibbs Cancer Center. He is a licensed clinical social worker and has spent over 20 years working in oncology. Chad has earned his BSW from Grand Valley State University and his MSW from the University of Illinois. He has overseen the lung cancer and screening program at Gibbs since 2018. In his spare time, Chad is an avid triathlete and competes in Ironman triathlons. He loves to golf and travel the world with his wife and daughter. Joining him today is Kara Grant. She is the Lung Cancer Screening Navigator at Gibbs Cancer Center. Kara is a graduate of the University of South Carolina Upstate. Kara focuses on early detection and lung cancer screenings within her role. She enjoys educating patients on conditions and options for their health care, and she values advocating for the patient's best plan of care. Outside of work, she enjoys spending time with her husband and their son. So today, Chad and Kara are going to help all of us better understand lung cancer screening, who should consider that, and what patients can expect if additional follow-up is recommended. They'll also share how the Comprehensive Lung Cancer Program helps ensure patients receive the right care at the right time. So Chad and Kara, thank you both very much for being here with us today, and I will turn it over to you to get started.
Yes, thank you, Julia, for the warm welcome. And again, I'd be remiss if we didn't mention the previous lung cancer screening opportunity that was given by Lisa Wallace and Jessica Lamb from Prisma. I think it was June or July last year. They really set up the importance of lung cancer screening. And so we're going to touch on a little bit about again, why that is important and how, if you qualify, you can obtain that, but also additionally talk about some of the advancements in technology and a comprehensive program. Lung screening is just one element of the lung cancer journey at this point. And so we want to talk about a little bit about what's happening in other spaces in lung cancer prevention and treatment. And so I think to understand it is to just dive right into some of the statistics behind lung cancer. I think what is apparent and somewhat difficult to discuss with people is just how devastating the mortality of lung cancer still is in America and in particularly in South Carolina. If you took all of the cancer deaths of breast, colorectal, and prostate cancer, those combined would still not equal the annual deaths from lung cancer. And so if we look at 2026, the most up-to-date through our ACS statistics, we're looking at nearly 230,000 new cases of lung cancer. And you can kind of see they're broken down between men and women. Interestingly, women just a bit more prevalent than men in the lung cancer diagnostic space. And if we look at overall deaths, again, pretty close to 125,000 for the year 2026. And so you see that shift a little bit to a little bit more in the men's death, but very, very similar with 60,000 plus deaths in our lung cancer statistics for this year. And so that's the broad picture. And now if we kind of hone in on South Carolina, this information comes to us from our lung.org. And this just tracks annually where all of the states kind of fall in with new cases of lung cancer. And so if you look at the green bar, that would be the national average. And then if you look at the highlighted orange bar, that is where South Carolina falls. And I don't think that it's really any surprise for those of you who know geographically a little bit about South Carolina, that we reside in the tobacco belt. You look at tobacco being a very popular crop in this southeastern part of the country. And so access to and marketing around tobacco has been prevalent for over 100 years now. And so typically we see most of the southeastern states, unfortunately, are at a little bit higher average of diagnosis of lung cancer than the country in general. And so you see that we have a 57.6% with a national average of 52. So about a 5% increase of South Carolina residents that would unfortunately be more apt to have a lung cancer diagnosis. That ranks 33rd out of our 50 states. And so I think one of the silver linings, it's not all doom and gloom from here, is if you look at over the last 5 years, we've improved. And I think a lot of what Kara and I are going to be talking about is why that has improved is the advancements in screening and actually also tracking incidental lung nodules and just being at the forefront of finding stuff very, very early. And I think we know across cancer in general, anytime that you can have earlier detection, it typically leads to longer survival. And so speaking of survival, we kind of slide into, in the cancer world, we really talk about 5-year survival rates. So upon diagnosis, what's the expected percentage to be alive in 5 years? Again, this is what keeps Kara and I coming in and working every day, is when we see numbers and statistics like this. And so on a whole, just under 27% in South Carolina of folks who are diagnosed will be alive in 5 years. And so that is one of those situations to where, how do we move the bar? How do we get better? How do we detect and treat cancers earlier to give people a significantly higher 5-year survival rate? And so if you, again, like the previous slide, look at the green bar, that would be the national average. And the orange bar, again, is South Carolina. You can see that we're below average in 5-year survival. And we have improved a little bit, but we still have a lot of work to be done. So now we'll kind of slide into staging and relative survival. And so when we talk about this, when a lung cancer is found, it is designated as a stage. And typically those stages are stage 1 through stage 4. Stage 1 being an early detection and stage 4 being a late detection. And so how they have it broken down here is a stage 1 would be really a localized lung cancer. And so it's specifically in a nodule or tumor and has not yet spread to any lymph nodes or any other locations in the body. A regional cancer, typically those stage 2, stage early 3s would be a regional finding. And so usually in the tumor and maybe some lymph nodes that are specifically in the lungs that can be treated. And then we move to that other category, which is your later stage 3s and stage 4, which would be a distant diagnosis. And so you see, unfortunately, between 2019 and 2023, almost 50% of the cases fall into that distant diagnostic category, which we know leads to the lowest long-term 5-year survival. And so to take those numbers and kind of move them to the right side graph, this is, again, specific 5-year survival for the entire country. We see that overall, as we mentioned before, under 30%. But the localized is usually in between 60 and 65%. So again, if we can find these lung cancers early, a very high percentage, over 50%, are living 5 years or longer. And then you see as we move into that regional or stage 3, we're at 34.6% in the stage 2, stage 3, and then our stage 4s are under 10% still. And so again, it just calls to the importance of early detection, especially in the lung cancer space. We'll move that national picture into more of South Carolina. And so these are our numbers for the previous year. And so you see our stage at diagnosis is right around 30% for that early. We're at 21% for the regional, which is, again, those stage 2 early 3s. And then our distant, more late stage 4 would be 43%. And then our 5-year survival, a little bit higher, puts us in the average tier nationally at 65%, 37% again is in that regional category, and then 10% is distant. And so now I'm going to turn it over to Kara. Kara has done amazing work with our lung screening program. I'll kind of tee this up for her. We started lung screening following a very important national clinical trial that was done in 2011. It was the National Lung Screening Trial. This was 50,000 plus patients from 2002 to 2004. And they stratified that group, roughly 26,000 in each arm of that. Half of the people received a low-dose CT, and the other half had a chest X-ray. And so they actually stopped collecting the data for this trial because it showed significantly the ability to pick up early stage lung cancers on the low-dose CT versus the chest X-ray. So this is one of those landmark studies that really changed how we do lung screening and really brought forward this new modality of what they call LDCT or low-dose CT, which is what our program uses to detect early lung cancer. And so we started our process around 2018 when the program moved to oncology. And at that time, we did roughly 600 low-dose CT screenings annually. This year, we are on target for nearly 6,000. And so you see the sheer growth of educating, reaching out to primary care physicians, reaching out to the community, letting people know that this screening exists and the importance behind it. So I'm going to turn it over to Kara to kind of talk a little bit about screening in general in our program.
Thank you, Chad. I think that he's done a wonderful job already just explaining the importance of why we want to catch these cancers so early, because it does make a big difference in not only your survival immediately, but as well as that 5-year mark and even past that. And so what I really want to emphasize is how do we put that into practice for our patients day to day? We know that we need to do it, but how do we do it? So like Chad mentioned, the study that happened in 2011, it kind of started the process of, okay, so what do we do with a low-dose CT to help these patients be screened? So a low-dose CT scan is going to screen for spots on lungs called nodules. And the reason that these are important to see is that not only if they are benign or something that would be able to just be watched, we can watch them and make sure if they were to grow or change, they are being able to be caught a lot earlier. These are covered through most insurances as well as Medicare. When we talk through the criteria, they just have certain criteria for the patients who are at a higher risk for lung cancer. But most of these are actually covered at 100% because they're considered a screening just like a mammogram is. Again, these screenings are able to help find lung cancer early, which is not only easier to treat, but more likely to be cured as well. These are the current Medicare guidelines for lung cancer screening. The reason that we follow these is that's one of the ways that patients are not having to have that bill for these. The ages have kind of adjusted over the last few years. We've also had some just criteria in general change, and that's all based off of evidence-based practice and how, the patients that we feel like are at most at risk at this time. And, these may change in the next few years. That's just something that is based off of legislature and those kinds of things. So Medicare guidelines, they do want you to be between the ages of 50 and 77. The pack year smoking history is you have to smoke a 20 pack year smoking history. And that can look like a few different things. 1 pack a day for 20 years would qualify, as well as 2 packs a day for 10 years. We also see a lot of patients who have smoked less than a pack a day, but smoked that for longer, and that would still qualify. So that's also a conversation to just have with a primary care doctor, or, we can also find that even just on the internet to see what your pack year smoking history would be. Patients do have to currently smoke or have quit in the last 15 years. And we also want these patients to have no signs or symptoms of lung cancer right now, there are a variety of these. Most common are persistent cough, chest pain, shortness of breath, those types of things.
And I just wanted to add that I think this is a very important element to this is the changing of the guidelines. And so following that 2011 landmark study, the requirements were age 55, and the smokier pack years was 30. And so as more and more screenings were done, as data was put into the National Registry, they went back and changed the guidelines to include more people and really reduce that pack year history. And so a handful of years ago, the eligibility requirements changed to what you see now, and has allowed all of these newer people to enter. And so I think it's valuable of, again, what we're finding in the results of screening is really changing eligibility and criteria to allow more people to have access to it.
I think that's really interesting that you guys are touching point on that, because that was when I heard you speak about that, Kara, that was my initial thought was, well, what was it before? And, you know, when you see 20 pack year history, that sounds like a long time, right? And so to know that it came from 30 to 20 is very interesting. And I'm interested to see if that will reduce in the future and keep going down.
This is the process of how a low-dose CT is performed. So if, you know, a pulmonologist or a primary care doctor identifies a patient as a person who would qualify for this low-dose CT, they would be able to order that test and then be able to get it scheduled. Once the test is completed, it is very simple. This is not a CT scan that would have contrast, so you wouldn't have to get a needle or an IV, as well as no lab work would be done. So it's a very simple procedure. It actually, the entire process is about 10 minutes, but the scan itself is only about 10 seconds. And then where we come in is most patients come up, we want it to be a once a year thing, not just one and done. And then if there are other things that are found and we need to do further workup or those types of things, you know, nurse navigators are typically where we fill in the gaps for those.
And that's such an important point Kara made, is this is a program. And so if you are part of a low-dose CT lung screening program, that means you come back annually, unless the recommendations change. And I think it's so important to educate not just our primary care providers, but also our patients that it's not a one and done screening. I think so often, you know, maybe people think I've smoked for a long period of time. I'm going to go and have this done. And if it shows no cancer, or if I have a clear finding, that's it. I don't ever have to worry again. And so we've really had to work hard at educating the public and even also our physicians that, you know, this low-dose CT is a program and that we need everybody to come back annually. And we're going to share some data later on in the PowerPoint that really talks to why that's important. Is that's where we're finding a majority of cancers now. It's not on the initial screening. It's when people are coming back for their third or fourth or fifth low-dose CT that we're picking up those small cancers and able to do something as far as an intervention to have that not be an issue for them anymore. And then another thing that I think I want to add to this is, you know, we're battling uphill with this being a relatively new technology. And so if you think about other cancer screenings like mammography, colonoscopy, pap smear, PSA, you look at statistically 70 to 80% of eligible patients for those screenings are doing that, are having those procedures done. We're hovering around 20% in the low-dose CT space. And so there is a lot of eligible people out there that are not coming. And this is where the education is really paramount, to get into these spaces, let physicians know the criteria, let patients know the criteria, and really fight for them to be an advocate for, you know, the why they need this. And so we have a lot of work to be done with only 20% of the folks who are eligible coming for low-dose CT.
We know there are a lot of risk factors for lung nodules that can be found. And these are, you know, we know patients, there are hard habits or things that they're exposed to that they may not even be able to prevent. So that's one of the things, you know, when we talk about it being a program, some of these things don't always go away. And so we want to just encourage you that if you are meeting criteria and we know you have those risk factors, that's why we want to emphasize it being a program, because even if it's not on that first scan and you're still being having those risk factors introduced into your life, we may find that on something else. We know one of the largest risk factors is tobacco smoke, which is what is introduced in the eligibility guidelines, but there's also other ones. These are just ones that would cause risk factors for lung nodules. Not necessarily all of them would be cancerous lung nodules, but they are ones that would cause patients to be a little bit more prone to developing them. Asbestos, a lot of exposure is, some people work in some different factories as well. Family history of lung cancer, that's also one that we see. Previous radiation therapy, we see that one a lot with breast cancer patients. And so if they've already had previous radiation therapy to that area, they're more likely to develop a lung nodule. And then as well as age 65 and older, and honestly, probably even younger than that. We see a lot of patients who have lung nodules by the time that they're 50 and don't realize it until they're being worked up for something else, which is how we find a lot of our incidental lung nodules. And then as well as another history of a previous lung disease or a current one, COPD, cystic fibrosis, all kinds of different things.
I'm curious from the viewer standpoint, in terms of tobacco smoke, do you think if someone's watching this today and they're thinking, I seem like I may be eligible for this, or my sister or my friend seems like they would fit into this category, do you think that they should bring that up with their PCP? Would their PCP usually bring that up with them? And then two parts to that, I'm curious, in terms of alcohol and tobacco use, I think it is well known that people are known to underreport that. And so it's either a feeling of judgment or a feeling of not wanting to fully disclose that in terms of stereotypes and things like that. And so what would you suggest in order for someone to take their health into their own hands and advocate for themselves?
Yeah, so we work a lot trying to educate our physicians, but the biggest advocate for your own healthcare is yourself. And so if you do feel like you are, potentially eligible or not super sure, we definitely want you to reach out to your primary care doctor and just bring it up and say, look, I heard about this. What's the process? Is that something that I would be eligible for? And then where do we go from here? And we do want you to be honest with those numbers because, talking about underreporting your tobacco use or alcohol use, because if you're right on the line or you're, maybe underreporting that, being truly honest may actually put you into that eligibility criteria, just with being honest with the answers.
And Julia, you touch on something that I think is so critical is around stigma. This is one of the cancers that I think, people are concerned they've caused it to themselves. Their behavior has created this situation. And so I think you're kind of always fighting that in our education space when we're reaching out is, there's a stigma to lung cancer. And so how can we break that stigma down to really put people's health at the forefront? And so we're aware of that. And so, again, regardless of the behavior, regardless of what you've done, if you qualify, let's see what's there. And then we have information and we can make a decision from there.
Thank you.
This slide is how lung screenings are classified. And so after the lung screening is performed, there is a doctor called a radiologist who would read those. And so they would look at the images and identify nodules. And at the very bottom of the report, they're going to put a lung RADS category on that. And so there's a few different ones. They range from 0 to 4. And then 4s do have some subcategories in those. Lung RAD zeros, one of the reasons that we talked about earlier of not having any signs or symptoms of lung cancer is also because of our lung RAD zeros category. And so if a patient has recently had a cough or bronchitis and been on antibiotics, sometimes there's some residual gunk is what I like to call that in your lungs. And so we want to be able to get a clear picture, because if we can't get a clear picture because there's something else going on, a lung RAD 0 may be classified, and then they would want to come back when you do have a clear picture. Lung RADs 1 and 2 are normally our negative or benign categories. Negatives just mean they don't see any nodules, and then, or they see some that really don't look suspicious. You've had them on your first screening back in 2020, and you had it on your screening in 2026. They don't see there any growth or anything like that. Lung-RADS 3 are probably benign. And so these, the most common recommendation for these is actually to come back in 6 months rather than that year, because they want to just keep a closer eye on it, that if it were to grow or change, we would know 6 months down the road rather than a year. These are solid nodules. They may be a little bit bigger in size. Sometimes patients come back and they drop back down into that 1 or 2 category the next year. So that's not necessarily meaning that it is a progression. And then the Lung-RADS 4 category, the subcategories are just able to identify them just a little bit better based off of size and characteristics. And that's where we want to have that further workup, whether that's getting you to a specialist, getting you to a nodule clinic. Just there's a lot of different things. And like I said, that's where we come in to help kind of guide each patient with where that goes. At the very bottom, there's also a S category. And so what that means is we found something else. The radiologist may see a breast finding. He may see a heart finding. And so we also want to make your primary care doctor aware of those. And this is a great tool because, you know, you had your lung screening and it was covered. And then we found something else that we are also able to catch. So not just identifying lung issues, but there's other things that can be caught as well.
And another reason we put this up is, and this is a busy slide and is very clinical, but one of the reasons we added it is wanted you to look at the percentages, and they're kind of small on here, but if you see Lung-RADS 1 and 2 is about 85% of your population. Mm-hmm. And so when you really think about, you know, people who come in for screening, 85% of those people are going to have, you know, basically what we call a benign finding. And so you move on to that 3 category, and that's about 10%. And so probably benign, negative, and benign, you're looking at about 95% of the population. And so those stage, you know, Lung-RADS 4s, those are only going to be roughly 5%. And so we're looking at a lot of different screenings, but just kind of wanted to give everybody a little bit of conceptualization on what that means. And so, you know, 95% of the, you know, the lung readings out there for low-dose CT are probably going to be in the benign category. It's the 4 A's, B's, and X's that we really want to keep an eye on, and that's the work that CARE is doing every day. Is you know, reaching out, contacting the primary care physicians, the pulmonologists, the patients themselves, and really putting together a plan for next steps. And so now that we've kind of talked about screening and the importance of it, this is, I'm going to say, a sense of pride for us.
Chad, would you mind going back on the presentation and clicking back one time and clicking forward? It's frozen. Perfect. Thank you.
Yeah. And so, again, we mentioned more screening and why it's important. I call this kind of our point of pride slide. And this is, you know, one of those areas where we're happy we're above the national average. And so this is the actual percentage of lung cancer screening done in South Carolina. We looked at our numbers at Spartanburg not too long ago. We're inching closer to 30%. Again, I think that has a lot to do with how long we've been around, how long we've done this, really the education on part of the lung team going out to physicians over the past 8 years now, really telling them the importance of this. But as a state, we've improved. You know, programs throughout Prisma, St. Francis have lung programs. The upstate is very well covered. And so I like to think that we're, again, trending in the right direction. Eventually, hopefully in my time, we get closer to those 70 to 80% screening rates that mammography and colonoscopies have. But this is a drastic change. Just a couple of years ago, you know, we were around 12%. And when I first started looking at this data coming out of COVID, which again threw a lot of screening programs into disarray because people were not going to their appointments. We were about 6%. And so we've tripled that in just a handful of years, which is very encouraging to see. And so again, all the wonderful work lung programs are doing are really driving this number up to hopefully one day get again to those 70 and 80% numbers the other screening locations have to celebrate. And so now if you kind of look, we're going specifically into Gibbs Cancer Center data. And so again, I had mentioned we have been at this since 2018. So the totals aren't going to add up because for preference of the slide, I didn't add 2018 and 19. But this just gives you an idea, again, of the importance of a screening program. Because as I mentioned earlier, we had issues with late stage diagnosis. And as you can tell here from this particular slide, over half of the cancers we're detecting through our screening program fall into that stage 1 category. And so this is an opportunity for those folks to have that cancer found early and to have interventions and treatments that allow them to have that over 50% 5-year survival and beyond. And so this just looks kind of categorically at our stages. Those stage 2 patients are often surgical intervention patients. And so they usually have very successful outcomes as well. And then our stage 3, stage 4s, I say it's always good to find somebody's cancer, regardless of the stage, because then we know information and we can further work that up and treat them how they need to be treated based on the staging of their cancer. And so a point of pride for us is now we're moving into that almost 500 cancers diagnosed through our screening program in the last 8 years, which is, the success of a lot of hard work from a lot of people. And this is what keeps us coming back, every day for our jobs is we see this transitioning into a space where we're giving people more opportunities, longer survival, and many options when we find these cancers early. And so our screening program has been wildly successful. And again, as I mentioned earlier, we're on target to do 6,000 this year. And so as I mentioned earlier, this slide I kind of wanted to talk about was where we're finding cancers. And so again, as we mentioned, low-dose CT is a program. It's not a one and done. But if you look at the blue line moving across, those are people that came in for their very first screening and a cancer diagnosis was made. And so you see back when we were kind of ramping our program up in 21 and 22, a majority of the patients that came in for their very first screening is where we were finding the cancers. As our program has matured and now people are coming in for their 6th, 7th, and 8th screening, that bar is beginning to shift. And you see last year, for the first time, our annuals, or what we call our follow-ups, cancer diagnosis outweighed our new patients. And so again, speaks to the importance of a program and not a one and done screening. And so we share this a lot with our primary care physicians as we're going out into the office, sharing data with them because they need to see why it's important for every year for them to send their folks back to us. And so a lot of questions are, well, how often do you find cancer doing lung screening? And it's not an incredibly high number. National average is usually anywhere from 1% to 4%, just depending on, again, location in the country you are, the types of patients you're screening, if you're a more rural setting, a more urban setting. But this has kind of been our data. And you see we've kind of been between 1.3 and 1.7% of the people who come in. And so as you see the screening numbers grow, the number of cancers diagnosed tends to grow as well. And so as we put 6,000 in this year, we should see our numbers a little bit closer to 80 cancers diagnosed statistically. And so more people coming in, 1.3 to 1.7% of those we're going to find a cancer on. Over 50% of those people we find cancer on is going to be an early stage. And so when we look at a lung program, screening is kind of what I call 50% of the bucket or the importance. And the other side of the coin is our incidental lung nodules. And so just want to spend a little bit of time when we talk about lung programs, it's really dealing with both of these populations. And so we have to look at different ways that we track and monitor lung cancer. It's involving a lot of different physician practices, primary care, emergency medicine, radiology, pulmonology, oncology, thoracic surgeons. All these people play a very vital role in our program. And so we've really worked hard over the last handful of years to streamline these two important populations into a lung program. And so when we talk about an incidental finding, I think the best maybe story to tell or situation to present is, say I was walking down the street and I went to step off the curb and caught my heel and fell down and landed on my shoulder, and now my shoulder's in pain. And so I think maybe something's broken. My collarbone doesn't quite feel right. So I might go in to the emergency room and have them check me out. And they, in the emergency room, just to kind of check to see what's happening, they order a CT scan of my chest and abdomen just to see if anything else happened. And so if this were my particular image that they pulled up, there's a spot in there. And so this is what we kind of call an incidental finding. It means they weren't intending to look at my lungs and find a nodule, but just because I happened to show up and have imaging done, they found something. And so much like Kara talked about with screening, that LRADs or those lung rads, there's also criteria for our lung nodules called Fleischner's. And basically what they look at is the size of that nodule. Is it solid? Is it ground glass? And then they look at, depending on 6 millimeters or below, 6 to 8, and 8 or greater. And so Fleischner's, really based on the radiology reading of that incidental finding, has a recommendation. And so Kara, again, handles our screening side. We have a nurse navigator named Jill who handles our incidental lung nodules. And so all of these screenings that come in through our emergency room, all 5 of our hospitals throughout the upstate, every day as these images are done, we now have artificial intelligence that goes into these radiology reports and pulls out the ones that are concerning and says these scans, these 50 scans from yesterday had an incidental finding that may need something to happen. And so Jill has a work queue through our medical record that every day she's going through and reviewing these to determine what needs to happen with these findings. And so typically our 6 and graders will go on to what we call our Lung Nodule Clinic. And so that is a dedicated clinic that we have here at Gibbs to where a patient can go with these incidental or screening findings that are a little larger and have a sit-down conversation with our nurse practitioner who specializes in the pulmonary space and really figure out next steps. Do we want to have some more imaging that's done? Do we want to have another CT? Do we want to send this person on for a PET scan? Maybe they need to have, maybe we want to see if we can get some tissue. So maybe they need a navigational bronchoscopy. And so the Lung Nodule Clinic visit is really this opportunity for a provider and a patient to sit down and figure out that follow-up plan. And so as I alluded to, we have in our building, the Lung Nodule Clinic, patients come in, have a conversation. It is usually a physician or a nurse practitioner. Our program runs through a nurse practitioner. And then again, they monitor and look at those nodules and continue to follow that patient over time. If things stay the same or they get smaller, they'll typically be discharged back to primary care. If nodules tend to grow, they'll continue to have conversations on what the next best step is. And so you heard me earlier talk about getting tissue. And so when we look at lung nodules, it's very, very important because we know a lot of different things can happen in the lungs. Pneumonia, infection. And so sometimes those lung nodules that look suspicious, The best way to know what they are is to go in and get a piece of that, or what they call a biopsy. And so this particular technology that's on the screen is the Ion Navigational Bronchoscopy robot. And we've had this since last April, and physicians use it. And it basically has a reticulating arm that connects to the trachea tube when someone is put under general anesthesia. And then a catheter is placed down through that tube into the patient's lungs. And they use very advanced CT imaging to map out specifically where that nodule in the lung is. And so it's like a GPS system. So the computer knows, based on that person's anatomy and their CT scan, where the robot needs to go and get a tissue sample. And they can do samples around 6 millimeters and above. So very, very tiny, a spot the size of a pencil eraser. They're able to go down and get a sample of that tissue, bring it back and look at it under a microscope to see, is it infectious? Is it benign? Is it cancerous? And so a huge leap forward in technology to get these answers on very, very small nodules in the lungs. And so here's an actual image from the robot. You can see the airway there, and the purple section there is the actual nodule that they want to take a sample of. So the physician will drive the catheter down there and park it, and then they slide different types of needles and forceps, and actually a cryoprobe, which freezes tissue. And they put all of those inside of that nodule to bring the tissue back up and look at it under different samples. And so this is just, again, a phenomenal technology that has allowed us to get answers to very small nodules that we had no way of doing that a handful of years ago. And we're now getting our second robot at our Pelham campus. And so we'll have one here in Spartanburg and one here at Pelham that's able to do this wonderful technology. Another piece that I think is important to a program, and this is sometimes the difficult conversations that maybe Kara and Jill are having, is tobacco cessation. And so we know, one of the requirements of lung cancer screening is tobacco use. And usually it's for a long period of time. That 20-pack years means typically people smoked for quite a while. And so we think definite benefit to a program, but essential at this point is we've got to have conversations with people about the benefits and the overall health benefits, not just in the lung cancer space, but overall health benefits of smoking cessation and why it's important to stop. And so you see, again, not surprised with our geography, we tend to be on the above average section nationally of smoking rate. We're just a little, as far as states go, we're 25th to 50, but as far as our percentage, we're just a little bit over the national rate. And so having a functional smoking cessation program is very valuable to have these conversations with patients of, you're entering a lung screening program. Stopping smoking is perhaps the most significant step you can take in helping reduce health risks. And so we want to make sure our physicians, our lung program, our team, everybody's reading from the same sheet of music and helping people be successful in tobacco cessation. And so our program actually runs electronically through our medical record. It's called Tell Ask Quit Manager. Instead of asking people if they want to stop smoking, which is an opt-in, a lot of times we used to do it that way, and people would tell us they had too much going on. They were just newly diagnosed. I'll talk to me next time, I'll quit. Now we make people part of our program. If they're an identified smoker in our medical record, we want to reach out to them and let them know the ways they can be successful in reaching the South Carolina quit line. And so we built this program and partnered with a group out of Canada that now anybody that comes into any of our Gibbs Cancer Center clinics or is in our LISW-CP program, they're going to be enrolled in our Tell Ask Quit Manager program, which they receive phone calls, text messages, and emails at an algorithm based on day 3, day 14, day 30, um, again, with the goal of connecting them to the South Carolina Quit line. So when they get a phone call or an email, it asks them through interactive voice response if they're an identified smoker, have they tried quitting? Are they interested in being transferred to the South Carolina Quit line? And so we want to actively engage people throughout their treatment journey, throughout their low-dose CT journey, to continually give them opportunities to engage in smoking cessation.
One thing I think that's important to add about this is the average patient attempts to quit about 7 times before they're successful. And so educating patients that just because you don't feel like you were successful that first time, you still can try again and should try again. Just as much as we want lung screening to be a program, that's a constant conversation that we want to encourage, because it's not always the first time is successful, and that's okay.
And looking at our data, which I'll show you in a second, it is pretty amazing to see how many people those first, at day 3 aren't ready, day 14, they're still not ready. And then by day 30, we have this, this change in, they've signed up, they've asked for services. And so it's really phenomenal to see that, as Kara mentioned, it's not always the first time you say you want to do this. Maybe there is a lot on their mind, but if you come back to them a couple weeks later and try and engage them again, maybe they're at a different space to hear the message. And so great point in that we want to continually to try and engage people to get them connected. And then here's just a little bit of our data as we're closing down. It just gives you kind of a sheer volume of, this is from 2025 in our Gibbs Cancer Center clinic. So patients that come in to our cancer center, there was 1,900 eligible patients, and 350 of them asked to be connected to services. So almost 20% of our cancer center population said, yeah, I'd like to talk to the Quit line. I'd like somebody to reach out to me to talk about this. And even more successfully is our lung screening program. And so again, you see a little bit of a higher population, almost 2,200 unique patients at that time last year. And we had 500 referrals to the Quit line. And so a little bit more of a 23% referral rate, but 850 patients from Gibbs and low-dose CT, we were able to move on to the South Carolina Quit line to provide them an opportunity. And so I think in closing, I'd just, like to say how important all elements of a lung program are to be successful. You can spend a lot of time in screening, and that's great. And it's important. And you can spend a lot of time in the incidental space and really tracking these people with these small nodules and figuring out what you need to do. You can spend a lot of time trying to get people to stop smoking, whether that's through the medical record, through one-on-one visits with a tobacco treatment specialist. But I think a lung nodule clinic, you spend a lot of time just really focusing on that. But I think when you add all the elements together and have this comprehensive look at how we deal with intervention, screening, diagnosing, all of those elements are critical. And so we continue to add to our staff, continue to grow in this space because, lung cancer mortality, as we mentioned earlier, is frightening. And we want to do all we can to give people the best shot. And so here's the connection to the Quit line. We always like to put this up in case there's somebody watching who says, how do I get to the Quit line, or what is that? They have, you can get on it through the web. You can get on it through 1-800-QUIT now. And so they can have many different programs that you can sign up for individually tailored, whether that's nicotine replacement, one-on-one counseling or coaching. They have all sorts, and it's free to the user. And so this is a program through the state. And so if this is something you're interested in, by all means, please reach out to our Quit line.
Absolutely. Thank you guys so much for that presentation. I think what stood out to me the most is that knowledge really is power here. You hear that said time and time again, but knowing knowing that there's access, there's resources, and there's access to that right within your community. You don't have to go far to be able to access that is really important. And I think one thing that I took away from this is if you are wondering, even if you're just curious, maybe this is something that I want to look into, then please ask your primary care provider about more information. You can also reach out to us here at Gibbs Cancer Center if you need more information as well, and we're happy to be good stewards of that and be able to refer you and have that conversation with your primary care with you as well. Um, I do want to thank both of you, Chad and Kara, for being here with us today and sharing your expertise with us. This is an area that I am educated in, but I also took things away today that I've learned. So I really appreciate that. And I'm sure that the viewer is thinking the same thing as well. A big thank you to all of you who've joined us today. We hope that you leave today's conversation with a better understanding of all of the things that we've talked about: lung cancer screening, lung nodules, how you have access to this care, how these screenings are performed, and also tobacco cessation. If it's something that you're thinking about, reach out to somebody, and also go back and refer to this slide for the quit line. There's multiple opportunities here right within your state to be able to help you with that. As we wrap up, we would like to leave you with a quote. We always do this at the end of the Prevention and Wellness series programs. So we like to leave you with a little something to reflect on. And today's quote is an African proverb: "If you want to go fast, go alone. If you want to go farther, go together." Thank you again for joining us today, and we hope that you'll join us again for another Cancer Survivors Park Prevention and Wellness series program in the future. Hope you all have a wonderful day. Thanks for attending.